Hello, thank you all for joining us at the KansasSIPP Webinar, COVID-19 and Interventional Pain Practice. Now I'd like to introduce Dr. Gupta. He is the president of the Kansas Society of Interventional Pain Physicians. He was ranked one of the top pain management doctors in Kansas City, and he is the president, CEO of Kansas Pain Management and founder, Neuroscience Research Center. Dr. Gupta, take it away.
Thank you. Good evening, everybody, and thanks for joining. As you know, that COVID virus, it was pretty unexpected, and including small businesses, medical practice, everybody has to kind of readjust according to how the things have changed during this pandemic. With that, there are multiple questions which came in for the physicians who are pain management doctors, including, what is the safe practice? How can we help our patients safely? How can we help our patients? What is the safety of the staff? What procedures we can do, what not? And there was also a financial hit, which many practices have taken. And, and one of the questions was, how can we survive or stay afloat on that? So there were multiple things. And then locally, one of the things which was coming again and again was, what does it mean to the folks who lives in Kansas? What does it mean to physicians based on the incidents which we have of the COVID cases, and what is the path going forward? So with that in mind, we thought that Kansas Society of Interventional Pain Physicians, we should put a webinar together in which what we wanted to do was, we wanted to discuss about risk mitigation and stratification for our patients, especially the patients from Kansas, based on in the light of the incidence of cancer, the COVID cases, which is fairly low as compared to the other states like New York. Then what are the best practices? Because there are multiple questions out there. Should we use the steroid? Should we not use the steroid? The patients who have COPD, should we treating them or not? And, and with that, other things comes up in mind is, we have to be careful that, while we're dealing with COVID pandemic, that we don't create an opioid epidemic. And so we have to create a balance between the two. The other thing is, how do we create a strategy going forward as the Kansas state is opening to create the safety for our staff and patient? And finally, the financial impact. What do we do to deal with the financial impact, and how we can get over as a team and help ourselves and our patients? So with that in mind, I put a panel together. So the first talk would be given by Dr. Amol Soin, who is the president-elect for American Society of Interventional Pain, well-known pain management doctor around the country. Then I have a good friend and a colleague, Dr. Dan Kloster. He's very well known in the Kansas metro area and also nationally for his different expertise and different procedures, including advanced procedures like intrathecal pump. And I thought he would be an appropriate person to talk about the best practices to help our patients. Then we have Dr. Mahua Ray. She's the director of pain management at Menorah Medical Center as well, and talk about the strategies for staff and patient safety. And finally, we have from Kansas metro area, one of the well-known CPA, Mike Peru, who has extensive expertise in managing physicians' practices specifically, and how to help them. And also with the, he has done extensive work on CARES Act, PPP, and give his some tips to the physicians and their small practices. So I think with that, I will have Dr. Amol Soin take over the podium and talk about the risk mitigation stratification.
Hi, thank you, everybody. Amol Soin here. I'm really honored to be included in this webinar. And I'd like to start by thanking Dr. Gupta for his leadership. And it's really impressive, the state of Kansas, what you guys have all done to get going with this webinar and how organized you are. It's really fantastic. Lakin, if you can move up to my slide, which is about the Asip Toolkit. What I'm going to talk to you about today is the toolkit that Asip has created to help you with your practice. And these slides were put together by Dr. Shalini Shah from UC Irvine. We were all on the committee together, myself, Dr. Sudhir Dewan, Chris Garibo from NYU, and Kartik Rajput. You can move on to the next slide, please. And what we tried to do was to come up with a way to help you guys risk stratify your patient based on guidance we got from the White House regarding the phases of opening hospitals, and outpatient clinics. And you can move to the next slide. And what we're looking at is, here's some of the guidance from healthcare systems and their capacity regarding PPE and all that from the White House. And that's what we use primarily to frame the toolkit. Next slide. And what it boils down to is a kit of things that you can use in your practice to decrease the risk of morbidity related to COVID, specifically in pain patients. And again, move on to the next slide, please. Part of the toolkit includes a couple of different things. First of all, here's a risk stratification chart. All of you actually, if you're ASIP members, you were emailed this today, and if you just type in ASIP in your search bar, you'll see we've actually been emailing this about every 3 to 5 days with different updates about how to reopen your practice. But the toolkit consists of a couple things. First of all is a risk stratification chart, low, moderate, and high risk. Each of these categories, the pulmonary status, cardiovascular status, body mass index, diabetes, renal, hepatic, they're all based on data, and we actually have the references in one of the slides. But we pulled this from the CDC to try to stratify if your patients meet these specific categories. Are there higher risk for having a severe complication related to COVID? Even if your patient is high risk, there's still a pathway forward to do elective procedures on them, and you can still do interventional pain procedures. But we just ask that you mitigate the risk, inform the patient of the risk through possibly an informed consent form, and also just to consider to do normal things in your office like social distancing, hand washing, wearing a mask, and other risk mitigation strategies. Can you move to the next slide? The toolkit, in addition to that, has a risk flow chart, which doesn't show up very well on this slide just because of formatting. But if you go from the top to the bottom, you can see a low, medium, and high risk. And what we decided is if your patient tests positive for antibodies, which means they've already had COVID and they've recovered, or they have documented recovered from COVID-19 and been asymptomatic for at least 2 weeks, you can just proceed with a procedure as you would do otherwise regarding safety. So you don't have to do any other extra safety precautions because this specific risk mitigation flow chart is related to COVID. And then it splits into moderate and high risk and gives you some ideas on what to do for those. If they're high risk, we do suggest to consider testing prior to doing an injection. You don't have to do that. This flowchart is clear to provide you operational freedom. It said to consider testing or consider delaying the procedure, but it might be smart to send your patient for a test if they are high risk prior to doing an elective procedure. Next slide. The toolkit also includes a couple of other things that are helpful for practitioners. Here's a frequently asked questions statement that we have. For example, what procedures I'm able to do right now? Should I use steroid in my injection? Should I sedate patients? And basically, these have been answered here for you to see. They're also distributed by ASIP. But just so you know, regarding steroids, there's not a lot of data behind it. We're fine with physicians using their discretion. We did say it's good to use the lowest therapeutic dose, and that therapeutic dose could be based on what you choose. But that is something to consider. Sedating patients, just because of the increased secretions, the potential exposure that comes from secretions, to sedate as minimally as possible, to try to avoid it if you can. But if you do have to do it, just consider taking precautions and risk mitigation strategies. Next slide, please. In addition to the frequently asked questions, here's some more. I won't go over all of these because they're available for you to see, so we can move on to the next slide. We also have a couple of other things in the toolkit. This is an informed consent form. Legally, if you don't like the term informed consent, I've seen some people put risk disclosure form for pain management procedures, but this is just an extra consent form where you are telling the patient that they could be at increased risk for a complication related to COVID-19. So you have a clear and open disclosure of that. And we also put in there something about steroids that we don't actually know whether it could make you better or worse, but disclosing that, hey, we are using it in this scenario, thinking that may provide you some benefit, and it's good to help disclose those to the patient. The other thing in the toolkit that you'll see is actually a checklist to open up a procedure. It's like a yes or no checklist that goes over basic stuff to help you jog your memory, like to make sure none of your medications are expired, make sure your RFA and fluoroscopy machine are working, make sure you have a social distancing policy, hand washing available, that you have a plan for masks for patients if you require them to wear a mask, or you're going to provide one for them, or maybe not at all. But it's a checklist that you can use, and the advantage of doing that is if you somehow get audited by a Department of Health official or a state board of medical licensure, you can actually show that you have this checklist and you made a good faith effort to mitigate the risks, which could be helpful for you in addition to reminding you about what to do. Next slide, please. And those are all the basic things that are in our toolkit, and these are the references. Thank you so much for including me. And I do want to mention that Dr. Gupta's leadership has been phenomenal, as I've been reaching out to every single state president in the country since I newly became president-elect of ASIP, and Dr. Gupta has been incredibly responsive. And we have been talking about potentially having an annual meeting once this COVID thing blows over. So hopefully, if that does occur, you know, God willing, towards the end of next year or next summer or spring or something, we could all get together live, and I think that'd be a lot of fun. So I'll turn the floor over to the next speaker, or to actually, yeah, right here, Dr. Dan Closter will be talking next. Thank you.
Yeah, hi. First of all, thanks to Dr. Gupta for putting this all together. You know, great job doing that. He asked me to speak on best practices. So a couple things, you know, this country is obviously very regional. And Kansas, so far, we've been, you know, fortunate not to have the worst by any means. But I think it's very important that we start doing something just to get our patients seen. So a couple stats that I just wanted to share, as I crunched some numbers earlier today. And out of the total COVID cases, Kansas counts for 0.5%, okay? And we count for 0.2% of deaths. So those are still real numbers, but you know, for us to have to do things like the rest of the country, you know, I think we're all in the same boat, wondering at what level should we get back to work. So with that said, a lot of this might be repetitive. Hopefully some of this is new, and I want to hit some highlights. The first is, how do we go about this? Telemedicine, I'm sure we've all done. So I'm new to telemedicine. My guess is a lot of us are. And I had never done it before, and now I do it fairly frequently. So we are probably doing 5 to 10 patients a day would be my guess. And that is the recommendation. If you can go to telemedicine, we go to telemedicine. This has actually been a very good thing for my practice. I've been doing this for over 20 years. And when I first got into this, we used to write patients 3-month prescriptions. And that's now really been kind of a gray area. And some of us are still doing this and some not. I'm on the not side, where I make patients come in every month and shake my hand and prove that they're still, you know, there and getting their prescription. And this has been nice for those patients where we can now do a call. But what are the regulations? And some of us may know these, some not, because it's been a little bit of a moving target. But the very nice thing is CMS and the insurance have changed what we have to do. So we can do telephone. So for the elderly patients that don't have an iPhone or an iPad, or quite frankly, just not the skill set, is we can do a telephone visit. How we do it in my practice is we start off and say, listen, this is going to be treated like an inpatient visit. You may get a copay. That's dependent on your insurance. We're going to bill this just like you were in the office. And then also, this is not HIPAA compliant. That's kind of how we put it in our letters and in our notes, so that the patient's aware of that. They say fine, and then we move on. My practice, we don't have the ability to e-scribe, but we have a patient or a family member come by and get the hard script. And so the DEA is the next step. The DEA has also lessened their burden for us. And if they're a known patient, DEA says that a telephone visit is also adequate. If you've never met the patient before and you feel that they need narcotics and you're doing a televisit for the very first visit, then you do have to either see them in person, or you need to have a FaceTime where it's secure. You're looking at them, they're looking at you, and that's the DEA requirement if it's a new patient. If it's an established patient, a telephone is fine. Now, as we know, you know, I do drug screen my patients, and, you know, we do all those kind of factors in trying to mitigate risk, but you certainly can't do that over the phone, but we can K-tracks. And I do K-Tracks all my patients. It's usually about 10 minutes of my day each morning. I go through my schedule and go through the K-Track. So I can still do that either telephonically. Now, for all of us that are interventionalists, a lot of around the country have been saying, well, we don't have to do procedures, you can give them medicines. And I do just want to remind people that the last epidemic was the opiate epidemic. I mean, obviously we're living with COVID, but I do think there's been some chatter out there about just placing these patients on narcotics and foregoing procedures, and that's not my opinion. My opinion is if patients hurt, we should treat them. If we can treat them simpler, then we don't need the procedure. Next slide, please. So this is the very next hot topic. This slide I'm going to leave up a little bit, so anyone who wants to screenshot this or take a picture. I have given this lecture over the years and had this come up all the time, as we want to know steroids in the immune system. Steroids, the way that we use them, it does not interfere with the immune system, and I feel strongly about that. And this is a very good article, a lot of science behind it, but it also pulls up, and it's current through February of 2020, so it's on up to date. And the question is, there's no doubt that steroids affect the immune system. Now, the question is, affecting the immune system, is that a problem? Well, for our patients, the way that we do intra-articular injections or epidurals is it's really proven not to. Some of this, there's never been a good study with epidurals, but there's been good studies with knee injections. But even a lot of these studies were done with patients that are on chronic narcotics. And part of this translates into vaccines, where these patients, the way we treat them, can still get live vaccines, can get attenuated vaccines. And so the science really says that even though someone's lymphocytes may be decreased transiently for hours, recovering in a day later, they are not at risk to have a live vaccine. And this is even with patients on high dose, which is more than we give. High dose can be up to a cumulative of 700 milligrams of prednisone. And if we're given 80 of triamcinolone 3 times, that's obviously less. And so these patients really, in my mind, are not at risk. And we've proven that over our careers, giving so many steroid injections and haven't seen an uptick. So personally, I just really like this article. It's an article I reference just for data to put on your desk if people are asking. Next slide, please. So now, what are the office-based procedures? And this is just, what are we getting back to? So what do we do? Well, I think we all practice very similarly. We're doing radiofrequency, we're doing epidurals, we're doing joint injections. All of these are considered low-dose steroids. They're not systemic, they're regional injections. And so again, the risk of increasing someone's infection really isn't proven out in the science. So epidurals for me is the highest. I use triamcinolone, it's 80 milligrams. The sacroiliac joint, I'm at 20 milligrams. A joint, I'm generally around 40. Trigger points have a trace, radiofrequency has a trace. So these are my office-based procedures, and I do think the Asip has done a very good job with their stratifying who's at low risk, high risk, and whatnot. So we take all those precautions with our patients, and we try to, we screen them. We don't do the testing yet, but we do their temperature. We take the staff temperature. We're cleaning the rooms. We're social distancing in the waiting room. We've taken out reading materials, things like that. And so we're trying to do our part because these patients do need treatment. Next slide, please. So the operating room. I have been operating. We've given patients options. We've said, listen, COVID's going on. You know it. I know it. We can wait. And for the population that we treat, it's really not an option for these patients. My guess is 80%, if not higher than 90%, have not wanted to postpone, even though they've been in a higher risk group as far as health status and age status. These patients aren't sleeping. They can't stand to cook dinner. They are just having a very difficult time. So again, we're taking the same cleanliness precautions, the social distancing precautions, the temperatures, the pre-screenings, the patient's family out in the car. But we have gone to the operating room with these patients again, talking the risks with them, but it's just been very important for the patients to get that treatment. So untreated pain, we all know, also has risk factors. Next slide, please. So screening, this has been already touched upon, but CMS has their recommendations, the joint statement in Kansas, and I'm going to kind of just leave that where it is. These are all published. I'm sure most of us are doing this. I personally am not testing every patient just because we really don't have that ability yet. That's certainly be something we can move to if it becomes more available, but we're really doing a history as far as travel, fevers, those types of things. Next slide, please. So who gets what? I do think there's an optics for doing procedures when others may not be, and other parts of the country may not be. We're all kind of into this together, but back to, Kansas has been more fortunate than some. But one thing I have done with my patients is we haven't filled the hospital history, and that's really standard of my practice anyways, but we've now been doing that for my operating room cases. And these patients are essentially all in the severe category. And so we have that kind of as, listen, this is why we're doing this. This is why we're going to the operating room. We're taking the risk. We all know the risk, and we're still doing an implantable device. Is these patients fill this out and they are scoring in the severe category. The Asip stratification, what we've mentioned, and Dr. Sowen has spelled out, I think is very good. And then we talk about reducing ER. These patients were going to go to the hospital, the ER, if they didn't have treatment. Next slide, please. So final thoughts, we all want to get back to normal. This is serious. We all get that. We want to be very cognizant of other people. I have talked to my representatives, and I don't want to put anyone in harm's way. If people aren't comfortable coming in, or the nurses aren't comfortable, or the vendors aren't comfortable, we certainly respect that. We've been very fortunate that the people I work with have wanted to do this, proceed, and also help the patients. But I really think it's good to show that we can come back and do these things safely, give people benefit, and at some point we've got to start this process anyways. And I think we can do this very mindfully and be an example for a lot of the other practitioners about how to do this in a thought out way that helps the patients. Next slide, please. Oh, I think that's it. So thank you for your time, and I'll turn it over to Dr. Ray.
Good evening, everybody. My name is Mahua Ray. I do both acute and chronic pain. And thank you, Dr. Gupta, and thank you, Dr. Amol, Dr. Kloster, and Mike. You guys have all joined us here, which is great to make our final decisions, and also just to see how we can proceed forward. I have special interest in practice management, so this topic is quite close to my heart. Let's go to the next slide, please. So I think Dr. Kloster already touched a lot of this. We have a low prevalence, we have a low mortality. We also, though, have the lowest rates of testing in this country, which we have to be aware about. We are very thinly populated, and we have a lot of small places where there is, multiple cases detected, like, for example, in meat plants, correctional facilities in Johnson County, because we had the first identified case here, and there is a lot more travel associated. So our first case was reported on March 7th, 2020, and lockdown was enforced rather early in Kansas City. I remember it was before St. Patrick's Day because everybody had plans to go to the plaza, and before that they closed the whole city down. And then we had a statewide lockdown enforced on March 30th at noon, and then we are starting our state opening on May 4th in a very CDC recommended phase-wise manner. And each county, so basically we look at the state, but we also have to look at each county, and that has its own timelines that may need to be observed. Next slide, please. So this is from Wikipedia just yesterday, and we can see how the cases rose. Currently, we have crossed 5,000 cases, only 137 deaths, so overall mortality is very low. And as Dan suggested, that compared to the rest of the country, we are minuscule. We did have our peak on April 30th, so we are already 2 weeks down, from that. So I think we are heading towards where, we can probably go into a phase 2 soon. Next slide, please. So this is from the, the Kansas Department of Health. So this is the phase 1, which we are currently at, which means we can have mass gatherings of no more than 10 people. We should be using masks when we go out in public setting, maintain a 6-foot distance, continue to encourage to work, remotely or do telemedicine. And then, any employees with symptoms should not come to work, and minimize or avoid non-essential travel, which has been probably the hardest thing for me in this pandemic, but that continues in the phase 1. So this is from the state. Next slide, please. So this is a very busy slide, but this is the latest from our county, which is where Dr. Kloster, me, and Dr. Gupta are practicing, which is Johnson County. And they, instead of choosing May 4th, have actually chose May 11th as the first phase, May 18th for phase 2, June 3rd, and June 4th. To understand these phases better, it's all over in the internet. You can go to CDC or you can go to any of the articles. But if we follow this, then we are still not in phase 1 where I practice as of yet. Next slide. So the first part of this is patient safety. A lot of this has already been discussed, the policies and procedures that every office needs to keep. The phone screening for COVID. So just like Dr. Kloster, we don't have the choice to test each and every patient. So we do a phone screen where we ask about temperature, travel. We basically use the CDC checklist and determine whether the patient is good enough to come face to face. When they come in the office, I will be showing a slide later on. We have a place where we do the temperature screening, give them a hand sanitizer, give them masks. We continue to encourage telemedicine. Telemedicine implementation was very easy in our practice because we already had a patient portal that was sending emails out. So we did not have a whole lot of issues with video conferencing. Our EMR is compliant and HIPAA compliant and attaches to the Zoom platform, Zoom Pro account. So we have been doing that. And then the check-in process changes, the social distancing, PPE, and hand washing. Next slide, please. Again, telemedicine, I think it was already been covered by Dr. Kloster. It is covering most of the telemedicine platforms. There are different codes for phone visits that you can also use. Patient has to give consent for telemedicine, identify the patient with name and date of birth, especially if you're doing it over the phone. The patient portal is excellent because the patient can actually enter all the details prior to an appointment. So a lot of the history and the review of system can already be entered in there, their medications. I have noticed that it's better to have 2 devices so you don't get behind on charting, or if you have problems connecting with your EMR, you can connect with a FaceTime or a Zoom Pro app. And we have used doxy.me as a good backup in case our Zoom platform does not work. Next slide. So what are the limitations of telemedicine? Again, has been touched on. New patients can be a limitation, very hard to examine the spine. You can do a little bit of range of motion, maybe see a scar. It's also not very useful for opioid refill patients. Of course, if they're well established, that's different. And then patients often refuse this kind of service as well. They do not like this service and they want to be face-to-face. Internet connectivity can be an issue. The EMR integration, which is great if you have it. If you don't, then you're typing on one computer, doing this on another computer. Patient may not have a smartphone. I have noticed a lot of patients forget their appointments when I do it at home. And then if the no-show rate is high, then that's a waste of providers' time. Next slide, please. So how to overcome these limitations? We have a few labs in the Kansas City area that will actually take the urine toxicology. They will just ship the cup to the patient and then give us the results. So we can do that. It's not without any problems, but it can be done. And then I already talked about how 2 devices can help. And also when you take verbal consent, make sure patient understands that may end up being a phone consult. So I've had this issue where we have gotten connected on the video platform and 5 minutes later we get disconnected. And then we call the patient back on the phone and they want to be back on the video and you're probably running out of time and you say, you know what, this might just be a phone consult. So have an office staff call the patient 15 minutes prior to the appointment. And also if they're refusing to set up an appointment, let them know that if the physician feels, the procedure will be scheduled as soon as possible. Next one. Next slide, please. Staff safety. So this is, for practice owners, including myself, this can be quite a task, getting all the employees back to work, meeting with them daily. And if you go on this OSHA publication, it talks about a lot of things that every practice or every business should be doing. A lot of things which small offices may not be able to afford, and you have to all the time think about the safety of your employees. So, going around just the engineering of the building, making sure all the vents are working, small things like that, to all the way of making sure that you have PPPs, keeping in touch with your practice manager as to how many PPPs are left, how much time. Like I know that we can only get 3 boxes of masks every day. So trying to make sure that we have enough supplies. Non-essential employees should continue to telework. We are having all the staff wear head covers, masks, and eye protection. The social distancing. So this again is a very big project for a small practice. Like in our practice, we had to, in order to social distance, we had to convert the lunch room into an additional office space. We had to use the conference room so that everybody is at least 6 feet apart. So that has to be thought before you ask the employees who are working from home to come back to work. The front desk, you can have plastic shields. You can block areas so patients can talk from far away. And then the patients wait in a car and brought in only when ready to see a doctor. You can check in with iPads so they can be sterilized, or use as little paper as you can possibly do. Try to do the consents via EMR or patient portal. And then in the waiting room, reduce the number of chairs. Next slide, please. So I'd like to play a video on the check-in process at our office. I don't think we can get the volume here. So usually the patient calls and then my front office receives the phone call, asks them which part of parking lot they are. We have named the parking lots as 1, 2, 3, and 4. So my front office can locate them. So in this case, the consent seems to be still on paper. We're trying to do a portal consent. We're working on that. The rest of the stuff they can do on the iPad. And then my office staff wipes off everything, including the pen, and tells the patient to wait in the car, and she will call the patient back for the procedure. And as Susie enters our office, you can see there's a little desk there for the hand sanitizer and a thermometer, where once the patient is gotten inside by my medical assistant, right where the white flask is, the patient will have to undergo a temperature and thermometer check. You can see how our waiting room has been kind of changed. The front office area has been blocked by chairs, so nobody can talk to our front office, less than 6 feet distance. Next slide, please. For the staff, we have to do the temperature checks at the beginning of the shift. So, you have to have an employee basically designated from 8 to 8:30 every morning doing that. You have to rearrange the office, prepare ahead, use the conference room, even make marks to remind staff not to come too close to each other. No gatherings at lunchtime, space out the lunchtime, one at a time, restrict socializing. Avoid medical device company reps to come visit the medical office. Try to do as much Zoom or phone meetings as you can. And then train employees to screen patients for COVID-19 over the phone on the day prior to the face-to-face appointment. And the last but not the least, the most important part is employee education. So every single day, employees will come and say they're not comfortable with this. Sometimes they'll say we need an N95. You might not have enough N95. Some employees might have other questions as to exposing their older parents. So, reviewing with them the CDC guidelines. And again, if they're not comfortable doing it, it's best that you allow them to do telework, because we are kind of in a transition phase. The state is open on 4th of May. Our Johnson County has not really opened till 11th of May. So we really have to work with HR and make sure that the employee is happy. We do not allow any visitors with patients right now, and if there is a driver, they wait in the car. Next slide, please. So the remote work, again, this should probably continue into phase 2, phase 3, phase 4. I was looking forward to the Asip meeting. I think it's now in September. So, you know, any conferences or anything in May or June are pretty much out of question. There are so many video platforms to explore for remote work. Always being mindful of HIPAA compliance. You know, employees have to be trained to remote work. You have to give them a laptop and all the thing, and also there can be conflicts with reporting their hours to their supervisors. So sometimes it's not as easy as it sounds, especially in a medical practice. So you have to, you know, maybe like Dr. Gupta has been having mainly daily meetings with Michelle, who's our practice manager, to discuss these things. So these things will have to continue, I think, all the way until we enter phase 4, which is in June. And then patient correspondence and televisit documentations have to be kept on track as well. So, for example, if a patient just calls, say, for an opioid refill or for pre-authorization for Lyrica, you have to make sure all that is documented in the EMR. So the quality of care stays the same. Next slide. Just to end my talk here, you know, just the staff training, which is the CDC guidelines on treatment, spreading, symptoms, location, prognosis. They will hear something in the news that coronavirus can spread 26 feet. Well, it can't unless you're sneezing with full force. You know, if you're an asymptomatic carrier, you have a lower viral load, you're not going to spread it unless you are like sneezing again. So there is a lot of miscommunication that goes on in between the employees, and we have to deal with those with just good education, that they are safe, and we want to keep them safe and try to have the least number of employees in the office to do a certain procedure or to conduct a certain visit. Thank you. Next slide. Also, I have a little summary here. I think we have discussed most of this. A little bit about sick leave. We do have to give sick leave to anybody who has suspected COVID-19 or is caring for someone with COVID-19. So every practice owner has to be aware about those things, because there are multiple new laws called the Family Medical Leave Act and EMLA, Emergency Medical Leave Act. So if there is an employee who has a parent, for example, with COVID, then you have to give them extended sick leave. And those are the things you want to address with your human resources. Next slide. Thank you.
Thank you. It's good to be with everyone. Thank you, Dr. Gupta, for inviting me in this presentation. I know a lot of you, and I hope a lot of you have been through this SBA program. If you haven't, time's probably running out. This program, which started back at April 3rd, was a program that was designed to help all of you with your payroll. SBA is a great program. I don't know if any of you physicians have used SBA in the past, but there's a lot of different loan programs that SBA takes on. I will have to tell you, this is the most efficient program that I've ever seen SBA do. Normally, SBA is 2 to 3 months of trying to get through their process. So to get through this as fast as they've been able to get through is just been amazing. So just a recap, because I'll tell you the biggest part of this payroll protection program is going to be in the loan forgiveness part of it. But just a summary, and I will tell you, this program, when it started on April 3rd, I think is when you could first put your applications in. No background, no regulations behind it. There was so much confusion as to how this program was going to function. And I will tell you, the second round, it just seems so smooth right now. The process is so easy. But recap, pretty much, you have to be a small business, which is defined by the SBA. You go through, that's why they ask for your classification. For physicians, practices, normally it's anything under 12 million is considered a small business. This loan starts out as a loan, but it can be partially forgiven or it can be fully forgiven. And that's going to be the key part of going through this process. Part of the speed behind this was the streamlining. I mean, and again, it depends on which bank a lot of the physicians were working with. Some banks went like full underwriting. I mean, they asked for financial statements, they've asked for personal financial statements, and now it seems like they're understanding it better because technically the only thing they really need is 941, some payroll registers, etc. No personal guarantee, which is great. You're not responsible at the end of it. No fees involved, because if you've dealt with SBA in the past, especially in their 7A program, it gets quite expensive on the fee side. And SBA is technically supposed to be a lender of last resort. And in this case, it didn't matter. You could go to any bank, and if a bank wanted to take you on, which then you were good. Next slide, please. So here's what when I went through this with quite a few physicians, one of the things that we got into was initially the documentation behind this. And part of the documentation created it was just different getting through the start of it. But at the end of it, it really is a pretty simple program because it's only based on payroll. So in the payroll calculation, which started off being a little difficult, actually ended up being pretty simple because it's really just based on your employees. It's based on making sure you've adjusted for the 100,000 limitation. And after that, I think the rest of it is going to get into the documentation of it. Next, please. Let's see, can you go to the next one, please? There you go. So this is an example that I developed working just with different physicians to make this process a little simpler. And if you haven't got the Paycheck Protection Program and you go to your bank and your bank says not doing it anymore, then your alternatives are going to get pretty limited, because without the bank, you're going to be looking at a peer-to-peer group like Cabbage, one of those groups, or Street Shares, which aren't really banks, but they can help you get some money if you need it. But this is the calculation, the form that I use to go through and basically determine what the loan amount's going to be. So, and that actually has worked very well in the banks, because we've worked with, I think, 8 different banks so far, and they all have loved this documentation, and it's made it a lot easier to get through the process. So next slide. Okay, so here is the big part of this loan forgiveness. And for those of you who have received your funds and you are now starting to make your payroll payments, the biggest thing behind this, and anytime you work with the government, there's going to be some complications in this. So first one is we're getting 2.5 times our average monthly payroll cost. Okay. However, we're going to evaluate this loan at the end of 8 weeks. So what does that really mean? Well, it was at the start, 8 weeks was going to start when the actual loan was approved. Now it's changed, and it's based on when the actual funds hit your bank account. So from that point, you have 8 weeks then to start your documentation to determine that you are going to hit 75% of your loan proceeds. And if you can do that, and that is for payroll, you have a great opportunity to get the whole loan forgiven. But of course, they had to put in a couple other little rules behind this. One rule is, so you start off with, and you might want to go to the next slide. You start off with the determining what was your employee base at the start. When you filled out your application, how many employees did you have? And then at the 8-week period, you're going to evaluate that again. And if you have a drop in the number of employees, then that's going to impact part of your forgiveness. So that was one reduction that they had. The second reduction that they're talking about is, let's say that you maintained all your employees, but you cut hours, which then results in cut in pay. Now you have to do a calculation to determine if that did you reduce it by more than 25%? And if you did, now we have another calculation that will then have to determine the amount of add back, if you will, because you won't get that forgiven. So there's a few things in there that it's going to be critical to evaluate this as you're working through this 8-week period to make sure you're on track, because I think a lot of you would want to make sure that you're not worrying about paying this back. I will say though, it is a program that even if you had to pay something back, and when I say that, what would that be? Well, let's say that you took these proceeds and you never used them for payroll and you used them just to pay all your vendors off. Well, that's not what the program was for, which could result in you having to pay back the loan, which is a 2-year loan at 1% interest. So probably not a lot of damage in doing that. So next slide. Okay, so when I talk about developing a plan, and this is really on your financial side, whether you're working in-house with it or whether you're working outside with your accountant, your CPA, but you really should be projecting out your payroll over this 8-week period, because you want to track that so you know if you're going to hit the 75% mark at the end of the 8 weeks. And if you do that, again, you're in great shape. But if you're not going to hit it, then you're going to have to look at making some adjustments. So what would the adjustments be? Well, that probably would mean that you would have to look at making some adjustments to the payroll, whether that's a bonus pay, whether it's an increase in pay. I mean, it almost sounds like if you got to that point, the amount of loan was probably overstated in the first place. Because technically, if it's done right, it really should work pretty darn close to the penny. So that's the big thing, is making sure that you are planning for this and not just waiting for the end of the 8 weeks and then coming up and looking at your calculations and going, well, did we have to pay something back or is it all forgiven? So that's the big thing. Next slide. Okay, so the forgiveness part of it, the first thing is, and looks better on not a little clouded out here, but the eligible costs. So again, number one, this whole program was based on payroll, and there's a laundry list of payroll items, which again got clarified in the final regulations behind this, but it's pretty well laid out now. But you also can utilize these funds for if you had a mortgage payment, the interest component on that, for your utilities. If you had to make lease payments, you can utilize it for that. So there was really very laid out areas that you could use these proceeds for besides just payroll. And that's where that 75-25 rule came in. So this first part of this is determine the amount of eligible. What is eligible for forgiveness? So, and I just used an example here so you could just get a feel for how this works. But ABC company here borrowed $100,000. Okay, so they have 8 weeks to go through this process. Well, in their situation, they only spent $50,000 of this on payroll costs, and then they spent $30,000 on rent and utilities. So what's going to happen to determine that how much is going to be forgiven is that because they didn't hit the 75% mark, means that the $30,000 that they spent on rent and utilities, not all of that can be utilized. So I put the calculation that the SBA is using to determine that. So here you can see that only $16,000 of the $30,000 is eligible for forgiveness. So in this example, of this $100,000 loan, you would have the $50,000 of payroll costs and the $16,000 of non-payroll costs. So $66,000 would be forgiven. So because I get this question all the time, if I don't hit the 75%, do I have to pay it all back? The answer is no. That's why at the end of the day, everybody's going to get something forgiven here. Whether you get all of it, it's going to be based on these calculations. So that's the first part, is determine how much of it's going to be eligible. The second part of it is you have to now go through and determine if you had a reduction in employees. So, and again, that is going to, and this is a little bit up in the air because your application should have asked you for number of employees, not necessarily full-time equivalent employees, which now the SBA's forgiveness program is based on number of FTE. So there's a little bit of a difference going on there. And I think that'll probably get fine-tuned here in the next few weeks as they work through some of these. But in this example, you can see that there was a drop as they had 30 employees and then they went to an average of 20. Well, now you have to take what was eligible, $100,000, and you got to reduce it by 20 divided by 30 because that's your percentage. It's not 100%, so you get a percentage of it. In this case, again, it reduced it down to 66,000 is what you would get to for forgiveness. So that is the second part of the calculation, is the reduction in employees. And so you have to look at it, because keep in mind, again, the program was designed to maintain the number of employees you had, whether they were working or not working. The program was designed to still pay people. Next slide. Okay, then you get into this third piece to it, which is the reduction in wages. And to me, this is, I mean, it really ties back. If you had a reduction in employees, you're going to have a reduction in wages. But it also could mean that you had the same level of employees, but what you've done is that you cut their hours. And if you cut their hours, now you have to determine, did you do it by more than 25%? If you did, now we've got another calculation to go through, which I've illustrated on here. So again, I'm not too concerned about, at least the ones that I've worked with so far in this area, because even if you looked at it at the end of 8 weeks and determined that you were down, you still can cure that by the end of June to get it back up without having any reductions. So there's still a process in here to help everyone as you work back through this and get your offices open and getting patients in and et cetera. So that's the 3 pieces that you got to look at on the forgiveness. Now, it just doesn't happen. So at the end of 8 weeks, each bank's going to have, which is probably going to come from the SBA on the application for it, but there will be this application. And this application, and your lender, it's not SBA making the decision on this, it's the lender that you're working with, and the information you provided that lender is going to make the decision as to how much you're going to be forgiven. My point on this is being proactive, meaning that, and if you go to the next slide, please. Being proactive means having this as you're working through it, you've already getting your invoices copied, you're getting copies of your payroll registers, your 941s, whatever payroll you need to update and document. And what I've done is I built a spreadsheet that is going to be used, and I actually work with a bank, one of my main banks that I work with, and we're going to be using this twofold. One, at the conclusion, this will summarize everything, and then behind all this is going to be all the documents, so that if you want to look at your payroll costs, you look at the payroll dates, you look at your payroll, behind that will be all the payroll registers that will support that. For the non-payroll costs, whether it's rent, utilities, etc., there's another sheet that goes with this, and behind that is going to be all those documents. So the documents roll up to the spreadsheet, the spreadsheets then roll up to this calculation, and then you have exactly what the amount that's going to be forgiven looks like. That's the end, the concluding piece to it. But the proactive piece to this is really utilizing a module like this, whether it's this or if you're doing it on
Hello? Can you hear me?
Yes, it seems like we've lost Mike.
That's fine. I think we're about to conclude here. So let's just put the slides for upcoming conference which we're talking.
Perfect.
Let's do that. So, friends, thanks for joining. So to conclude, if you have any questions, feel free to reach out to me. But I want to take this opportunity to mention about that we are going to have our Kansas Pain Society meeting in April or May, hopefully next year in 2021. And before that, we'll plan like a plenary meeting, like a think tank meeting in fall this year. Hopefully everything is fine. So you will get all the details very shortly from me. We'll have two meetings. One will be a think tank meeting in fall, and we are planning to have it at Four Seasons in Lake Ozark, followed by the annual pain meeting, which will start a tradition, having once a year. And this time, the first time we are thinking it will be in Lowe's in Kansas City. And feel free to reach out with suggestions. If anybody is interested in joining the planning committee, helping me out in organizing the meeting, if you have any interesting topics you want to suggest, which pertains to local Kansas geographical area, I'm open to suggestions. Or if you want to help me out in planning meetings and any details with that. And very soon we will also issue a statement on behalf of KansasSIPP for safe practice guideline for pain management procedures. And with that, I think we'll conclude our webinar today. Thanks for joining me and the crew. And thanks, Dr. Kloster, Dr. Coyne, Dr. Ray, and Mike.
Thank you all.
Okay. Thank you.
Thank you, Michelle and Lakin.